welcome to the deep dive. Today, we're tackling something that can be really unsettling. Idiopathic sudden sensorineural hearing loss. You might hear it called ISSHL. It's basically a rapid, really unexpected loss of hearing. And, even though it's technically a medical emergency, it feels like maybe it doesn't always get appreciated as such.
That's absolutely right. And you might think it's pretty rare, but the numbers actually suggest it's, well, more common than we often think. The really fascinating part, I think, is that despite just tons of research, over 800 articles published in the last 30 years alone, we still don't know the specific cause in, the vast majority of cases. Something like 88%.
88%, wow.
Yeah, which is why we stick that label idiopathic on it. Just means the origin is unknown.
Okay, so idiopathic unknown origin. When we say ISSHL, what are we actually talking about? What are the defining features?
So clinically speaking, it's defined by a hearing loss that just comes on very abruptly. Often people notice it first thing when they wake up.
Right when they wake up.
Yeah, pretty common. And it usually just affects one ear. Now, the loss itself has to be pretty significant. We're talking at least 30 decibels.
30 decibels.
Yeah.
Can you give a sense of what that means in practical terms?
Sure. It's roughly like going from hearing a normal conversation fine to maybe only just catching a whisper. It's a noticeable drop. And this happens quickly, within a 3-day window, across at least 3 adjacent frequencies on a hearing test, the audiogram.
Okay.
Now, the thing is, most people don't have, a recent hearing test lying around for comparison. So often, they're comparing the bad ear to their good ear to gauge the loss.
That makes sense.
Yeah.
And is it just the hearing loss? Or do other things come along with it?
Oh, yeah, definitely. Other symptoms are quite common. People might get tinnitus, that's, a ringing or buzzing sound in the ear. They might also feel what we call oral fullness, like the ear's plugged up or feels under pressure. And sometimes, dizziness or even proper vertigo can happen too.
Okay. You mentioned it might be more common than we think. What are the actual figures looking like?
Well, historically, the estimates were maybe 5 to 20 people per 100,000 each year in the U.S. That works out to maybe 4,000 new cases a year originally.
Okay.
But if you actually calculate based on those incidence rates across the whole population, it's probably more in the ballpark of 15,000 to maybe even 60,000 new cases annually.
Wow, that's a huge jump.
It is.
Yeah.
And more recent studies are suggesting even higher numbers. One found 27 per 100,000. And it seems to climb quite a bit with age, like up to 77 per 100,000 in older adults.
77.
Yeah. Some researchers are even arguing now that maybe we shouldn't call it rare at all. They're suggesting figures potentially as high as 160 cases per 100,000.
Goodness, those numbers really change the perspective, don't they? Makes it seem much less like a freak occurrence.
Exactly.
So who typically gets this? Is there a particular profile?
The average age seems to cluster around the mid to late 40s, let's say 46 to 49 years old, typically. And it hits men and women pretty much equally. What's kind of surprising is that there's no clear link to, seasons changing or even having had a cold or an upper respiratory infection recently, which you might sort of intuitively expect, right?
Yeah, you might think a virus could be involved.
Yeah.
Okay, so that paints a clearer picture of what ISSHL is. Is there any good news here? Any upside?
Yes, definitely. There's a pretty significant silver lining, actually. In quite a few cases, somewhere between 30% and maybe 60% hearing can actually recover all by itself, spontaneously, no treatment needed.
It's 30 to 60%.
Oh.
That's quite a range, but still, that's encouraging. Spontaneous recovery.
It is. It offers some hope right from the start.
Okay, so given this suddenness, the mystery around the cause, but also this chance of natural recovery, what's our goal for this deep dive today? What are we trying to figure out from all the medical literature you've looked at?
Well, our main mission is twofold, really. First, we want to explore that puzzle, the why. What are the leading theories about what actually triggers ISSHL? But maybe even more importantly, we want to focus on the treatments. What does the medical evidence actually support? What's proven to be effective in helping people manage this?
Got it. Potential causes and evidence-based treatments. Okay, let's dive into the why first then. Sounds like this isn't a new problem scientists have been looking at.
Not at all. The very first scientific report mentioning this specifically dates all the way back to 1944 by DeClain.
Wow, 1944.
Yeah. And since then, just a whole host of potential causes or mechanisms have been proposed. The list is long.
Like what sort of things?
Okay, so we're talking about issues with blood circulation, potential damage from toxins, ototoxicity, physical trauma, even neoplasms or tumors. Vascular occlusions, blockages in blood vessels, that's been a big one.
Okay.
Viral infections, as you mentioned, leaks in the tiny membranes inside the inner ear, the labyrinthine membranes, immune system problems, so immune-associated diseases, maybe an abnormal stress response within the cochlea itself, unusual tissue growth, direct damage to the cochlear membranes. It's quite a list.
That really covers a lot of different biological systems. Have any of these theories gained more, traction or evidence over the others?
Well, several have been looked at pretty closely. Early on, there was quite a bit of interest in what's called a hypoxic etiology, basically a lack of oxygen getting to the inner ear.
Hypoxic low oxygen.
Exactly. Some animal studies showed that things like noise exposure could actually reduce the oxygen levels, the PO2, in the perilymph. That's the fluid surrounding the hearing cells. And the idea was this lack of oxygen could mess up the critical sodium and potassium pumps in the organ of Corti, that's the sensory part for hearing, and that could lead to cell damage.
Interesting. Okay, so low oxygen. What about the blood flow idea, the vascular occlusions you mentioned?
Yeah, that's another major line of thinking. Circulatory derangement. Back in 1980, a researcher named Bilal proposed that occlusive arterial disease blockages from clots, emboli, or even vessel spasms could be a key mechanism.
And that influenced treatment, I assume?
Absolutely. That theory was a big driver behind using vasodilators, drugs meant to widen blood vessels, hoping to improve flow. That was a common approach for a while.
No, but is the evidence still strong for that? Is it mostly about blocked arteries?
Well, this is where it gets really interesting. A study in 2001 looked specifically at young, otherwise healthy people with ISSHL, and they found these patients actually had significantly lower blood pressure compared to controls.
Lower, not higher.
Lower, which suggests that maybe, in some cases, hypotension, low blood pressure could be a factor. And it definitely makes you pause and think, maybe vasodilators aren't the right approach for everyone, right? Especially if their pressure is already low.
That's a real contradiction.
It is. And it's worth remembering the inner ear's blood supply doesn't have the same robust autoregulation as, say, the brain. It's potentially more vulnerable to these swings in blood pressure.
So the simple blocked pipe idea might be too simple.
It seems that way. It highlights that it's probably not just one single blood pressure issue causing ISSHL across the board.
Okay. What about other health conditions? Do things like diabetes or high blood pressure play a role?
They seem to, yeah. There's definitely an observed pattern where ISSHL can recur, happen again in people who have diabetes mellitus or hypertension or dyslipidemia, that's unhealthy cholesterol or fat levels.
Okay.
And other studies have specifically linked cardiovascular risk factors, things like high systolic blood pressure, diabetes again, high cholesterol, even early markers of atherosclerosis, plaque buildup, and something called endothelial dysfunction, which is a problem with the lining of blood vessels. Those have all been associated with a higher risk of getting ISSHL.
And it sounds like this might be more than just an ear problem then. The implications could be wider.
Very much so. I think one of the most significant findings, and maybe a bit alarming, is that ISSHL can actually be an early warning sign for an increased risk of stroke.
A stroke? Really?
Yes. One study followed patients over 5 years and found that those who'd had ISSHL had a 1.64 times greater risk of having a stroke compared to a matched group without sudden hearing loss.
Wow. 1.64 times. That's substantial. I don't think most people would connect sudden hearing loss with stroke risk.
No, probably not. But it really underscores that maybe we shouldn't just see ISHL as an isolated ear issue. It could potentially signal a systemic vascular problem.
Okay.
And sort of related to that, researchers have also seen elevated levels of something called the neutrophil lymphocyte ratio, or NLR, in ISSHL patients. That can sometimes be a marker for other ischemic conditions, too, where tissues aren't getting enough blood.
So we've got oxygen levels, blood pressure high and low, cardiovascular health, stroke risk. Is there a main theory trying to tie these threads together?
Well, you're pointing right at a major debate, actually. There are these competing sort of multifactorial theories, the idea that multiple things contribute.
Right.
If you look at the American literature, often a viral infection is put forward as a likely trigger. But then in European literature, you often see more emphasis on vascular problems, the blood flow issue.
But is the viral evidence strong?
That's the issue. Finding a specific virus consistently linked to ISSHL has been difficult, and treatments with antiviral drugs haven't really shown clear success. So the evidence there is, frankly, pretty weak.
That must be frustrating for researchers trying to nail this down.
It definitely is. But one interesting integrated theory that's emerged tries to combine these ideas. It proposes an immunopathological process.
Immuno, meaning the immune system is involved.
Exactly. The idea is maybe a virus initially triggers an immune response, but that immune response then causes inflammation in the small blood vessels of the inner ear, something called perivasculitis.
Inflammation around the vessels.
Right. And that inflammation could then restrict blood flow and oxygen delivery to the cochlea. There's also some biochemical evidence looking at abnormal activation of a specific factor inside the cochlea, nuclear factor kappa B, in response to various kinds of stress.
So a complex chain reaction possibly involving a virus, the immune system, and blood flow.
Potentially, yes. It's an attempt to integrate the different pieces.
Okay, so with all these potential, sometimes conflicting causes, it's probably no surprise that figuring out the best treatment has also been a bit of a journey.
That's putting it mildly. The fact that ISSHL is likely multifactorial with many possible underlying issues has led to, I think, over 60 different treatment protocols being investigated over the years.
60.
Over 60, yeah. It just highlights how tricky it is to treat something effectively when you're often not entirely sure what caused it in the first place.
Right. Okay, so given that complexity on the causes, let's really shift focus now to the treatments where the evidence is stronger. You mentioned earlier that steroids and hyperbaric oxygen therapy seem to show the most promise. Let's start with steroids. What was the basic idea behind using them?
Well, the initial rationale was pretty straightforward. Steroids are powerful anti-inflammatory drugs, right? So the thinking was maybe inflammation and associated swelling edema within the delicate structures of the cochlea were contributing to the hearing loss. Reduce the inflammation, maybe you prevent further damage, maybe even reverse some of it.
Makes sense. But it sounds like maybe they do more than just reduce swelling.
It appears they do. Subsequent research has suggested several other ways steroids might help. They seem to protect the cochlea from certain inflammatory mediators like TNF-alpha and NF-kappa B, which are part of the immune cascade.
Okay.
They might also help increase blood flow within the cochlea itself, which could counteract any ischemia, that lack of blood supply we talked about. And there's evidence they help regulate protein synthesis and fluid balance in the inner ear, specifically in a vital structure called the stria vascularis.
The stria vascularis.
Yeah.
That's key for the inner ear's function, right?
Absolutely. It maintains the electrical environment needed for the hair cells to work, so steroids could be acting on multiple fronts.
That's quite a range of potential benefits.
Yeah.
So what does the actual clinical research say? How well do they work?
Well, there's a lot of literature. Going back, a 2001 review suggested that combining steroids with vasoactive agents, those blood flow drugs seem to improve outcomes in certain types of hearing loss. Then, a key study in 2005 by Slattery and colleagues found significant improvement when they gave intratympanic methylprednisolone, that's injecting steroids directly through the eardrum into the middle ear.
Injecting it right in?
Yeah. They did this specifically in patients where taking oral steroids first hadn't worked. And it helped.
Interesting. So that intratympanic route, does it offer advantages over just taking pills?
It seems to. A double-blind study in 2008, really good quality evidence, found that combining intratympanic dexamethasone, another steroid, with oral prednisone actually gave the best results overall.
Combination therapy.
Exactly. Now, things got a little more nuanced by 2011. Some research suggested maybe intratympanic injections alone were just as effective as taking oral steroids as the first treatment.
Okay.
But other reviews around the same time still emphasize the value of the injections, especially as what's called salvage therapy, meaning treatment used after the initial approach fails. Though the benefit of combining IT and oral was still a bit debated then.
Salvage therapy.
Yeah.
So a second chance if the first line doesn't work.
Precisely. And a 2012 study found that using IT steroids as salvage therapy did improve hearing in over half the patients, especially those with certain characteristics like maybe less severe initial loss, mainly in the lower pitches.
So it sounds like these intratympanic injections became a more established option then.
Definitely.
What are the main pros and cons compared to just taking oral steroids?
Okay, the big advantages of injecting it are, one, you can get much, much higher concentrations of the steroid right where you need it, in the inner ear fluids, the perilymph.
Higher local dose.
Much higher. And two, you drastically reduce the systemic side effects. Oral steroids, especially at high doses, can cause issues like blood sugar problems, mood changes, weight gain, bone thinning. the list goes on. With IT injections, you mostly avoid that.
That's a big plus, especially for people with other conditions like diabetes.
Huge plus. Plus, they got the dose because the doctor administers it. It's targeted, usually done right in the office, generally well tolerated. It's a great option for people who can't or shouldn't take systemic steroids.
Makes sense. Are there downsides to the injections?
There can be, yeah. Some potential local side effects, pain during the injection, maybe a small, usually temporary hole or perforation in the eardrum, sometimes middle ear infections or temporary dizziness. Rarely, it could even make hearing worse, though that's uncommon.
Okay. And how do oral steroids stack up overall, despite the side effects?
Well, oral systemic steroids do have a reasonably high success rate reported in many studies, maybe 50% to 80% recovery. But yeah, those potential side effects are always a consideration.
Right. What about the big picture studies, the meta-analyses that combine data from multiple trials? What do they say about steroids?
Good question. There have been several. One from 2016 by Gao and Liu suggested that combining IT injections with systemic oral steroids might be better than systemic alone, especially for people starting with really severe or profound hearing loss.
So combination again.
Right. But then another meta-analysis, also 2016, by Zhang and colleagues, actually found that using IT steroids as the initial therapy might lead to better hearing outcomes compared to starting with systemic steroids.
So maybe starting with injections is better. It seems the evidence points strongly towards IT steroids having a key role, either alone, in combination, or as salvage.
That seems to be the trend, yes. They offer clear advantages in terms of targeted delivery and fewer systemic risks.
Okay. Let's move to the other main treatment you highlighted, hyperbaric oxygen therapy, HBO2. What's the basic science or rationale behind using oxygen for hearing loss?
Okay, so the rationale hinges on the cochlea's biology. It's got a really high metabolic rate, it works hard, but its blood supply is relatively scarce, especially in critical areas like the stria vascularis and the organ of Corti.
Right, those key structures we mentioned.
Exactly. They need a constant, high supply of oxygen to function properly. And they get most of that oxygen by diffusion from the surrounding fluid, the perilymph. Now, way back in 1983, Nagahara and colleagues actually measured oxygen levels in the perilymph of ISSHL patients and found they were lower than normal.
So there's evidence of that hypoxia, the low oxygen state, in actual patients.
Correct. So the fundamental idea behind HBO2 is to flood the system with oxygen to overcome that deficit.
How does breathing oxygen in a chamber achieve that better than just, say, breathing oxygen through a mask?
Great question. It's about pressure. Breathing 100% oxygen at normal air pressure definitely increases oxygen in the blood and subsequently the perilymph, but not dramatically. Inside a hyperbaric chamber, you're breathing 100% oxygen at increased atmospheric pressure, typically 2 to 2.5 times normal sea level pressure. That pressure gradient forces vastly more oxygen to dissolve directly into the blood plasma, and from there, into the body fluids like the perilymph. Animal studies have shown almost a 10-fold greater increase in perilymph oxygen levels with HBO2 compared to breathing oxygen at normal pressure.
Tenfold. That's a huge difference.
Massive difference. The goal is to saturate that inner ear fluid with enough oxygen to support those metabolically active cells, even if blood flow is compromised.
Are there other potential benefits beyond just delivering more oxygen?
Yes, potentially. HBO2 might also help reduce what's called ischemia reperfusion injury. That's damage that can happen when blood flow returns to an area after it's been cut off. It can also help reduce edema or swelling, and it seems to have some anti-inflammatory effects too.
Okay, multiple potential mechanisms there as well. So what does the research show about using HBO2 right from the start as a primary treatment?
Well, a lot of the research actually looks at HBO2 combined with other things, usually steroids. But there are studies looking at it more primarily. A randomized controlled trial, or RCT, by Schwab and colleagues in 1998 showed significant hearing improvement with HBO2 compared to a control group, especially when started within 2 weeks.
Within 2 weeks, okay.
Another RCT in 2001 by Fattori's group found HBO2 was superior to a medical therapy they were using, but critically, only if it was started really early, within 48 hours.
48 hours, that's a very tight window.
Very tight. Later studies like Rasick in 2003 and Dundar in 2007 also reported significant hearing gains with primary HBO2 compared to other medical treatments used at the time.
So some positive results for early primary use. What about using it as that salvage therapy again when steroids or other initial treatments haven't worked?
This is where the evidence for HBO2 gets particularly compelling, I think. A 1995 RCT by Hoffman showed HBO2 improved hearing even after standard medical therapy had failed.
Even after failure, okay.
Yes. And then Lamb and colleagues in '98 analyzed several trials and concluded that HBO2, used as an add-on therapy even after medical failure, could offer benefit, especially if started within about 2 to 4 weeks of the onset.
So there's maybe a slightly wider window for salvage.
Potentially, yes, compared to that very early primary window. Several studies in the early 2000s, like Marchesi and Murakawa, also reported hearing improvements in a good number of patients who got HBO2 after their initial treatments were ineffective.
So it seems like even if things don't look good initially, HBO2 might still offer a chance.
It really appears so. It led the American Academy of Otolaryngology Head and Neck Surgery Foundation, in their 2012 guidelines, to recommend considering HBO2 within 3 months of onset.
Up to 3 months.
Up to 3 months is a potential option. And more recent research keeps reinforcing this. A 2013 RCT by Kavorovich found HBO2 salvage therapy was actually better than salvage IT steroid injections at most frequencies, particularly in younger patients or those with less severe loss initially.
Better than the injections in some cases.
In that study, yes. Another study by Yang in 2013 suggested IT steroids, HBO2, or even using both together could be beneficial salvage options. And Pezzoli in 2015 found significant improvement with HBO2 salvage compared to just continuing steroid therapy alone.
So a strong case for HBO2 is salvage therapy. What about chronic cases? Someone who's had this hearing loss for, say, longer than 3 months.
Yeah, the evidence there is much weaker, unfortunately. Some early, smaller studies hinted at some benefit, but that Hoffman RCT from 1995 specifically looked at chronic ISSHL loss lasting longer than 6 months. And it found no significant difference between getting hyperbaric oxygen versus just breathing hyperbaric air, essentially a sham treatment.
So not much hope for long-standing cases then.
It seems HBO2 is most effective when used relatively early in the disease course. The benefit seems to diminish significantly over time.
Okay. You mentioned HBO2 is often used with other therapies, especially steroids. What does that combined research show?
Right, there's a substantial body of work here. While some older studies looked at combinations with things like carbogen gas or nerve blocks, the real focus in stronger, more recent studies has been HBO2 plus steroids.
And what's the verdict there?
Pretty consistently positive. Fujimura in 2007 found adding HBO2 to steroid treatment improved the recovery rate. Alamoglu in 2011 reported the best hearing gains occurred with oral steroids plus HBO2. Filippo in 2012 confirmed a positive additional benefit from adding HBO2. Capuano in 2015 found the highest response in recovery rates when HBO2 and steroids were used together. Hosokawa's 2017 review also showed a clear benefit for combining HBO2 with intravenous steroids.
So the synergy seems real. The combination is better than either alone.
The bulk of the evidence strongly points that way, yes, especially for moderate to severe cases, and again, particularly when treatment is initiated early.
Early intervention keeps coming up as key.
It really does.
Okay, before we summarize the treatment landscape, are there factors that help doctors predict who might recover well from ISSHL regardless of treatment? Prognostic factors.
Yes, definitely. Researchers have identified several. Back in the 70s, with older treatments, things like having hearing loss mainly in the low tones and not having vertigo were considered good signs.
Okay.
With modern steroid therapy, some factors associated with poorer outcomes include having vertigo or dizziness, starting with a very profound level of hearing loss, and, crucially, a delay in starting treatment.
Delay again. So getting help fast really matters for prognosis too.
It seems to, yes. Studies looking specifically at HBO2 found better gains if treatment started within 14 days. Other studies suggest better outcomes overall if patients present within just 7 days of onset.
1 week. That's fast.
It is. Also, having certain underlying conditions seems to worsen the prognosis. Things related to thrombophilia, blood clotting issues, or cardiovascular risk factors like hypertension, diabetes, high cholesterol, smoking, those are often linked to poorer recovery.
What about how bad the hearing loss is initially? Does starting off worse mean less chance of recovery?
It's a bit mixed, actually. Some studies, like that Hosokawa one from 2017, found that worse initial hearing loss was actually a predictor of a better prognosis with combined HBO2 and steroid treatment.
Worse was better. How does that work?
The thinking might be that if you start lower, there's simply more room for improvement, more potential gain to be seen. That same study also found younger age, under 60, and early presentation, less than 7 days, were favorable. But interestingly, vertigo and diabetes didn't seem to affect outcomes in their cohort, so there's still some variability in findings.
And what about kids? Is it different for them?
It is a bit different. The incidence is lower in children, maybe around 11 per 100,000. And doctors have to consider a wider range of causes, like congenital issues or even non-organic hearing loss.
Non-organic, meaning no physical cause.
Right, sometimes psychological or functional. But interestingly, when children do get ISSHL, they actually tend to have better recovery rates overall compared to adults.
That's good news for them.
It is. And similar to adults, having tinnitus and getting treated earlier seem linked to better outcomes in kids too.
Okay, we've covered a huge amount of research. If we try to synthesize all this, looking at the big picture, the meta-analyses, the systematic reviews, what are the main conclusions about treating ISSHL?
Well, there are summary tables in the literature looking at case control studies and RCTs for HBO2, for instance. And while there are always limitations like it's hard to do a perfect sham control for HBO2.
Right, you can't really fake the pressure easily.
Exactly. But despite that, the evidence consistently points towards a benefit for HBO2, especially when used early. The Cochrane reviews are really important here. They're considered the gold standard for evidence synthesis.
And what have the Cochrane reviews found for ISSHL treatments?
All right, so for some treatments, the news isn't great. They found the effectiveness of vasodilators remains unproven. They found no benefit for routine antiviral use. The Cochrane reviews on systemic steroids have actually yielded somewhat conflicting or unclear results over the years, concluding their value wasn't definitively established based on the available high-quality trials.
Even steroids. That's surprising given how widely they're used.
It reflects the challenges in conducting perfect trials, perhaps, and maybe variability in patient populations. They also found intratympanic steroids were roughly equivalent to systemic, but the clinical significance of the difference wasn't totally clear.
So, Cochrane is cautious on steroids alone. What about HBO2?
This is where it gets significant. Multiple Cochrane reviews updated several times between 2005 and 2012 have consistently shown a significant benefit for adding HBO2 to standard therapy for ISSHL.
A significant benefit. Okay.
Yes. They found it improved hearing thresholds across frequencies, was particularly beneficial for those presenting early, and had a favorable number needed to treat, the NNT. That means you don't have to treat a huge number of people with HBO2 to see one additional person benefit significantly.
That sounds like a pretty strong endorsement from a rigorous source.
It's considered strong evidence, yes. It's why the Undersea and Hyperbaric Medical Society recommends HBO2 for moderate to profound ISSHL, especially within those first 14 days. The Otolaryngology Academy, as we said, gives that broader window up to 3 months for consideration.
Right. So it really boils down to steroids, especially IT or combined, and HBO2 as the treatments with the strongest positive evidence base.
That's pretty much the conclusion from the high-level evidence reviews, yes.
Okay. So how does all this translate into practice? If someone shows up at the doctor's office with sudden hearing loss tomorrow, what should happen? What do the guidelines recommend for managing these patients?
Right. The American Academy of Otolaryngology guidelines lay out a pathway. First, assess the patient, rule out other obvious causes for the hearing loss. Second, confirm the diagnosis with audiometry, that hearing test.
Check the hearing levels properly.
Exactly. Third, evaluate for any retrocochlear pathology problems beyond the cochlea, like tumors on the hearing nerve, often with an MRI. Then, treatment.
And treatment starts with?
The guidelines recommend offering either intratympanic steroid injections or systemic oral steroids as initial therapy. Often, the practical approach is to start oral steroids immediately and make an urgent referral to an ENT specialist who can then consider IT injections either initially or if the oral steroids aren't working well enough.
Okay, steroids first line. Then what about HBO2?
The guidelines recommend discussing or offering HBO2 as an option, particularly within that 3-month window from onset. The typical protocol is breathing 100% oxygen at 2.0 to 2.5 atmospheres. That's the pressure usually for 90 minutes a day for 10 to 20 sessions.
10 to 20 dives, as they sometimes call them.
Right. And importantly, the guidelines specifically recommend against the routine use of those other things we mentioned, antivirals, thrombolytics, vasodilators, antioxidants, because the evidence just isn't there.
So focus on steroids and HBO2.
Those are the therapies with high recommendation levels based on the evidence. And they also stress the importance of counseling patients about the condition, managing expectations, and discussing options like hearing aids or cochlear implants if the recovery is incomplete. And, of course, staying under the care of an otolaryngologist throughout the process, including during HBO2 therapy.
Makes sense. Finally, just briefly, let's touch on the bigger picture impact. Hearing loss isn't trivial, is it?
Not at all. It carries a huge socioeconomic and health burden globally. It affects employment, social interaction, mental health. It's actually the third leading cause of years lived with disability worldwide.
Third leading cause. Wow.
Yeah, so conditions like ISSHL contribute to that burden, and the potential for treatments like HBO2 to significantly improve hearing function. We're talking average gains of maybe 19 dGs in moderate loss, up to 37 dGs in severe loss in some studies. That's clinically meaningful improvement that can make a real difference in people's lives, reducing the need for hearing aids, improving communication. It has real value.
Absolutely. This has been incredibly informative, a really deep dive into ISSHL. I think the key takeaways are clear. It's complex. Often the cause is unknown, but early treatment is vital. Steroids are a mainstay, but the evidence strongly supports adding hyperbaric oxygen therapy, especially early on, often in combination.
That sums it up well. Prompt medical attention is crucial if you experience sudden hearing loss. Don't wait.
Definitely don't wait. Okay, and on that note, a final thought for you, our listener, to ponder. We've heard the incidence might be increasing, and there's this potential link to serious issues like stroke. So, thinking ahead, what further research do you believe is most critical? Where should the focus be to really crack the code of ISSHL and improve treatment even more? Something to think about. Thanks for joining us on the Deep Dive.